So as always, thank you everyone for joining us today. Before I turn it over to our team there in central office, I did want to point out a couple things on our website that I think may be helpful for folks. So allow me just a moment here to share my screen and take you on a quick little tour. So you should see our division landing page here. And I know that I've received lots of requests and questions about one of those things being our self-registration portals, as well as some training and events that are occurring. So I'd like for you to take note that here toward the bottom of that landing page under the popular sections, there's a tab that says Community Support. If you'll click on that Education and Learning link, that will take you to this page. On this page, you have a bit of a one-stop shop when it comes to that education component. That first tab, you'll see a newly added event / training calendar. Please know we've just put this up and running, so it will continue to grow, and I've reached out to other areas and other team leads. So this will continue to become more robust as we go along. In addition to that, here's the section that describes our webinars. If you click on this link right here, it will take you to the upcoming webinars, as well as give you access to previous webinars and things like that. You can also get to our webinar pages through this navigation box on the right side. Although we haven't done a monthly podcast for a while, since we've been having these weekly webinars, you can go back and listen to those earlier podcasts that Val did from the Director's Desk edition. Currently, under the video section, we do have some things here. This is one area that we look to be able to make more robust as well. In addition, the Reliance self-registration portals. I'm sure that most of you have had a moment where you've had to wrestle those with the new guidance that we've put out. We've tried to make a one-stop shop here so that it makes it easier for you and your team to navigate each of those portals. Know that the employment support self-registration portal is different than our content portal. That employment support self-registration portal includes all those courses that providers have access to be able to meet those employment support service requirements. The content portal, that houses some of our DD created content. It houses the Missouri Abuse Neglect course. It also houses those 3 refresher courses that we pushed out in guidance for first aid, CPR, and med aid training. And because we've noticed that as folks have logged in, there's been some confusion if they were logging in the correct portal, we have went as far as to color code the landing page. So if your people log into the employment support portal, they're going to have a purple landing page. If team members log into the content portal, they're going to have a green landing page. So helps make a quick and easy discrimination. The other piece that I wanted to make sure that I pointed out to folks this morning, which you are most likely aware of, but just in case you're not, we have updated this case management county status page. Hopefully this allows for a little bit more of an easy read. You will notice that 2 counties were added to resume in-person activities, and that those were changed to a green font, just giving you that green light. I know that there will be some additional conversation about this as we move forward today, so know that here's where you're going to get your one-stop quick information. And with that, I am going to turn it back over to the team.
Hey, good morning. This is Gary. I'm going to start it off. Val is off today. I don't know who approved annual leave, but I don't think we're going to do that again. But anyway, so I'm going to cover a couple items from the governor's press conference yesterday, where Mark Stringer presented some new approved funding items out of CARES Act for the department. The first one was $20 million for COVID provider grants for DD providers. So on our webpage, there's a new document posted out there that has a lot of information about that. From the DD COVID webpage, there's the DD Operations Provider Guidance section, and under that is a Provider CARES Act funding link to the document. You pull that up, it's got my fake signature on it. But it kind of goes through a description of who's eligible and what's being funded and all the dates. So it talks about how much funding, who's eligible, how to apply. I mean, how much is my allocation, and what are the eligible dates, the deadline, and how long it takes to receive the payments. All that information is there. Point I want to make is providers do not go to the website to apply. We have the list of who's eligible for these payments, how much they're eligible to apply for. The regional offices are contacting those providers. So if after a couple weeks you're not contacted, you may want to contact a regional office if you think you're eligible. And it's for providers of residential habilitation, group home and ISL, and also providers of day habilitation, medical and behavioral, as well as providers of employment services. And the procedure codes that, the eligible procedure codes are listed on that document as well. So that should give you information. If you have, and if you still have questions, you can contact your regional office or contact central office. We'll be happy to answer those questions. So that, and there's also links to the documents. So there's 2 attestations. The provider will need to fill out an attestation for the residential services, and there's a separate attestation if you're a provider of employment and day habilitation services. If you're a provider of residential services, you're going to have to provide documentation and fill out an invoice form. So all those instructions are coming out, and you can also go look at the forms on the website.
It's on the screen now. Heike has pulled it up on the screen.
Heike has pulled it up on the screen. Great. So if you see, I mean, just enter stuff. If you have some questions now, go ahead and enter that in the chat. Second thing that Mark announced yesterday at the press conference for DD was funding through CARES Act for Station MD. So that was $3.2 million to carry us through December 31st. And that's, you know, for all the Medicaid waiver participants. Anything beyond that, unless the declaration is extended, anything beyond that, the state will have to find funding for, and a lot of that will depend on our utilization. And I know you're seeing a lot of public awareness stuff coming out, trying to get people familiar with it, get comfortable with it, and trying to encourage people to use it, because how much we use it will greatly affect our ability to carry it forward. And with that, I will turn it over to Wendy.
Good morning, everybody. So I'm going to take the Station MD thing just one step further. Our utilization is much lower than we would have expected, and so we just want to put a plug in to help people and encourage people to use that. We monitor EMTs as they come through, and I know that I saw one yesterday that had an example where Station MD could have and probably should have been utilized, and the example was that it was an individual in a residential program became symptomatic, and what they did is they called the primary care physician for guidance. But they waited and waited and didn't hear back from the primary care physician. And so several hours later, they took them on into urgent care. Urgent care checked their oxygen saturation levels, which were very low, and they immediately sent them to the emergency room where they were admitted into the hospital with COVID. So in that case, instead of waiting on a call back from a primary care physician, a call to Station MD would have gotten an immediate assessment and direction to the ER for further care and testing there. So in that case, we could have just really reduced the response time in getting medical care to the individual. I'd encourage everybody to really know what your primary care physician's practices are. I know in mine, they will say messages will be we will listen to messages at the end of the day, and you'll hear back from us within 24 hours. If you have other arrangements with your doctor then that's great. And if they're going to get back to you right away, that's great. But just know what the expected turnaround time is when you put in a call to your primary care doc. And use Station MD to help out in those cases. They're going to send communication to the primary care doctor. They're not going to replace that doctor. So please help us get that utilization up, help us take some of that pressure off of the direct care staff trying to figure out what to do and worrying about the clients that they're taking care of, and making sure that they know that it's just a phone call. It's real easy to just do that. I also wanted to talk about the uptick that we're starting to see in positive cases within our system, within our network. it is really starting to get our attention. As an example, last month in June, we had 21 cases that were reported within our network on our EMT system. So far in July, we've got 93 cases. So, and where we're really seeing the uptick in those cases is in the St. Louis region, Springfield, and Central Missouri region. Well, and the Albany region hadn't had any up until July, and now they've got 11. So we've had some other cases reported throughout the other regions, but those are the ones. Albany region had an increase of 11. Central Missouri had 20 reported so far in July. Springfield and St. Louis Regional Office both have had 21 reported just in July. So we're really taking note of that. Need you guys to be taking note of that and making sure that everybody is really being diligent with their precautions. Perhaps when we opened up, things that some people I know just in the general community tended to kind of relax their protective measures and thought that we were on the downhill slide of this, and so statewide we're seeing increases, as well. So be sure that you're working with people to wear masks, socially distance, and that type of thing. One other thing that in relation to this that we are watching closely as well is we're starting to see day programs enter into the equations as they have opened up. And that's not to say that the day program of the staff are responsible for the infections of people, but it is people, when we opened up day programs and people start going to day programs, the opportunity for exposure, both to be exposed and to expose other people, grew exponentially. So if you've got 10 people that came back and they all came from 10 different homes, then you're bringing the exposure from those 10 different homes into the day program. Along the way, we're exposing people through transportation routes, if maybe they're riding with other people that are being dropped off at sheltered workshops or other places. And so just trying, our getting back to normal and opening up some of these programs has just really increased the opportunity for exposure and the need for us to be extra careful and look at what we're doing. So we need to be sure that we are assessing people who are appropriate to go to day program, that they can socially distance, that they can wear a mask, that they don't have underlying health conditions that are going to increase their vulnerability or risk to the disease. Both families and residential providers and day program providers need to be comfortable with the protocols that are in place in each place in order to protect folks. So the day programs need to be comfortable that residential programs and homes are exercising precautions when at home, with what is their visitor protocol, how are they doing visiting, are they going out in the community, are they social distancing, what is their cleaning protocols. Everybody needs to be asking these questions of each other. Residential programs and family homes consequently also need to be knowing what the day programs are doing and how they are protecting folks who are coming into the day program, and they're minimizing any exposure there, and that they're comfortable with that type of risk. What is the cleaning protocols, and how are we distancing and trying to keep people safe. We know that we can't eliminate every exposure and all exposure. There's going to be risk when we come back to the community and get more engaged, but just really asking that everybody has to be diligent in their own area of responsibility, but also a little bit nosy about the other areas that people are coming from too. So it is just part of your job, and I'm asking people to not be offended if they get asked questions about what the cleaning protocols are, or what is your policy around going out in the community. Are you going to movie theaters? Are you going to dine-in restaurants? What kind of activities did you do last week? Are they traveling? Are folks going home? Are they traveling out of state? Those kinds of things. It's okay to be nosy. You're just trying to protect everybody. So please take some of those things into consideration. A couple examples of things that we've seen that have come through. In one case, it was an asymptomatic person that came into a day program that we found out later, or the day program found out later that there was family members at home that were positive and symptomatic at the time, so perhaps they shouldn't have been in the day program or come to the day program at that time until we knew if the family members were positive, which they did turn out to be positive. And so that caused a lot of just some exposure there. That the day program did a wonderful job in responding to that. No fault on the day program side. It's just an example of how we need everybody to be extra cautious. I know that people are ready for a break, that they would like to have people get back to some sense of normalcy. And so it's really tempting. It can be really tempting maybe to send somebody on to day program when maybe you need to be more cautious and keep them home. Another example that we had was, it was a residential program that sent someone that was positive for COVID, but they were at the end of their symptomatic stage. So they, I'm sure, thinking that they were on the downhill side, they were healing, they were in the recovery part, they were significantly improved, and so, again, thought it was safe. Perhaps they weren't contagious. They were still contagious. They got into the day program and spent some time in the day program when they themselves still had symptoms that day. So there again, there was a breakdown on the day program side to do screening. If they had done screening at the door, the person would have been turned around and not even allowed to enter the building. So please, please, please really be diligent about your protective factors, about your precautions that you're putting in place. It is keeping the client safe, it is keeping families safe, it is keeping your staff safe and their families safe. So please just know it really, really can be the difference between life and death. So please take that seriously, and we need to be diligent about the screening protocols and when we're sending people and going out into the community. We have a responsibility to the rest of the community too, to not create exposures, not just, that we don't want our folks to be exposed, but we can also, if we're not diligent, be exposing other people to the virus when we know we've got it. I also want to move on and talk a little bit about the in-person monitoring and that whole process that we're going through. There's been some questions about, we're getting a lot of good communication from TCMs and providers out there that are sharing information about their county data and information, local information that we might not have. Thank you for that. We need that. A lot of people asking for their county to be added to the remote monitoring only, monitoring list, and we appreciate that. Keep those emails coming. There's also some confusion perhaps, and I think Val touched on this last month as well, but I'm just going to reiterate it, that it can be confusing when you're looking at the state data off the DHSS website and you're getting information from your local county health officials and they don't match. They will rarely ever match because a lot of counties are keeping information in real time. As cases are reported, they're entering it into their system, and so those numbers just keep ticking up throughout the day. But on the state side, we only take all those numbers and aggregate all those numbers one time a day, and I think it's at 2 o'clock. Is that right, Carrie? At 2 o'clock, and DHSS updates their numbers on the website at 2 o'clock with what they have received from all the counties at that point in time. So don't be surprised if your county data does not match the state data. It rarely will. It's a timing issue, but I want to assure you that Val and Carrie and the team that's reviewing all of that data and making decisions on the counties have all that data that is being reported by the county health departments. They already have that, the prevalence, the 7-day trends, the 14-day trends. They're looking at all of that. I want to reassure you of that. What they don't have access to is the stuff that we have seen some people report, like summer school closed down because there was an outbreak, and so all summer school in a school district closed down. Those kinds of things that are going on. There was a revival in one county where a lot of people with the church came together for a revival, and so that was good information to have, and lo and behold, there was an outbreak, I think a week or a few days after that we were seeing an uptick from that. Lots of singing and happiness going on, but that singing really, really spreads those droplets and those particles really well. So those are the kinds of things that are really helpful for Val and Carrie to know about, to also consider when they're reviewing the data. I want to reiterate, send the emails. We had originally said if you have emails and information you want to share and request your county be considered to be put on that status list, to send it to your local TCM TAC, and then they would forward it up the chain. What we're getting, though, is emails from pretty much every direction. So I think the easiest thing for us to do to make sure that, hopefully to eliminate people from getting their email bombarded with multiple emails on the same county is, or potentially even worse, missing an email about some county information, is to send your information to the DD mail box. It's ddmail@dmh.mo.gov. Send it to that mailbox, and then we'll be sure that we get all of those emails rolled up to Val and the team for consideration there. If you're a state staff, that's not to say that we don't want providers to still communicate with their regional offices. They're absolutely encouraged to do that. We want our regional staff to also know what is going on and what is out there. But for our state staff, if you don't see the DD mail on the email when you receive it, then go ahead. I'm asking you to go ahead and send it on to the DD mail yourself, and that way we be sure we get it through that one route. We'll be looking for just that one route to get all that county information from. If you see that the provider or the agency has already sent it to the DD mail, then you don't need to do that. Just be assured that it's getting to the right place. But I think that will help reassure us that we're seeing all the emails that we need to see. Along the same lines, I want to remind folks that the only person that has authority to put a county on this remote-only list is Val. Please know that they take this extremely seriously. They are looking at all this data daily, if not more than once a day, and it's all being considered. Nobody's taking it lightly, but the only person who can put a county on that list is Val. So if what your option is as a provider or as a TCM agency, if you think that you have a situation that you should do a remote-only visit with, that is what that pre-planning tool is for. That is your opportunity on a case-by-case, house-by-house basis to identify that location as a remote-only visit and document why you're only doing it as a remote-only visit. But you can't get agreement from, don't try to work with your regional office staff to get agreement that your agency is only going to do remote-only visits, because the only person that can provide that answer and has the authority to say that can happen is Val. So I just wanted to reiterate that. I also want to, while we're talking about the remote only and the in-person visiting, I know it is really uncomfortable for a lot of people. People are scared. They're seeing the numbers going up, wanting to be extra cautious. We should be extra cautious. And by going to this next step of the in-person open-air visits is our first step to help everybody develop a comfort level with getting back out, getting comfortable that they can protect themselves, that they can protect the people that they are working with, and still do their job and monitor and keep people safe and do that. If you have people that you are concerned about, if you are we are starting to get some emails and calls from public administrators and from families who are concerned about their family member in the home. They haven't been able to see them. They haven't been able to see the home. They're getting reports that maybe the home is in poor condition or whatever. If you are getting those kinds of reports, and we will share those with you, regardless of what the status of your county is, you need to go monitor. If you're getting a report from a public administrator that they have received concerns for the welfare of the person in that home and they can't see the home, or they've gotten reports that the living conditions are poor, you need to go monitor. You can do that safely from outside. You can look through windows. You can look through patio doors and see the home. You can see the individual. You can talk with them on the phone. If you have a closed door or a closed window between you and the person, even if they are a positive, you're not going to contract the virus through a closed window or a closed door and talking with them on the phone. So you can safely do that monitoring. So keep that in mind. We need all support coordinators to be thinking about the bottom line is the most important thing. Our first line of responsibility is to ensure the safety and welfare of the people that we're serving. Providers, I'm also asking you to be sure that you are finding a way to get your management staff back out there and monitoring if you haven't been already. Providers, we are giving some notice. We haven't set a date, but there will be a point in time that you're going to have the ability to do a virtual visit. You're going to have video capability, whether it be through a smartphone or through a tablet or a laptop that has a camera on it. So we will be working with you to come into compliance with that request. Getting a lot of questions lined up here, which is good. We'll work with you on that. I don't care at this point if you just get one device that has that capability and you pass it around from home to home and you coordinate with support coordinators about when the visits are. I know some of our TCMs have actually got equipment for the providers to have that remote capability and have been doing those virtual visits from the very beginning. So thank you to those county boards who have helped to supply our providers and our families with that remote technology so we could do that visit. But we have to see people. We have to start seeing people one way or another. So please work within your teams to strategize and get ingenious about how we can do these visits safely. Please feel free to call your regional office to brainstorm, call me, call whoever you would like. We're all here to help you problem solve and brainstorm about how we can do it. But we have to avoid any opportunity or prevent any opportunity for us to have a bad result, and then we can't defend the monitoring that we've got in place and how we've been doing monitoring. So please document. If you're not seeing someone in person, you need to document why and what you're doing instead. Let's see, I'm going through, I feel like I had one other point to make. Carrie, did I make the point that you were wanting me to make as well about monitoring? Okay, she's nodding yes, so that, just wanted to be sure that I got that. One thing to keep in mind as you're going out in those counties, a lot of the reason why we see spread along the along the highways is because as people are traveling, they're stopping at convenience stores to go to the bathroom, to get a snack. They're going into fast food restaurants to get, a meal on the way to or from here or there. And so to the extent possible, take snacks with you if you're going out and doing your monitoring. Minimize your need to have to stop and get a snack or take a cooler with you with some snacks, with your lunch, with waters and those kinds of things. So just be thinking about all those kinds of things to keep yourself safe. And I just want to acknowledge that I know that people are tired. It's already been a really long haul, and it's been 6 months, but it's only been 6 months. We are looking at this going on the rest of this year and probably well into next year, where we're going to need to really be diligent and keep our guard up and protect ourselves and the people that we're serving. You know, you've got staff working in the homes. I know you're short-staffed. They're working long hours. They're working overtime. They are stressed. They are tired. And in some cases, they've moved in and are living in the homes in order to keep people safe. So just anything, and it's understandable that people are just tired, they're scared, there's anxiety. So please, anything you can do to just increase your monitoring, to know that if you've got staff that are just at a breaking point, that you're well aware of that and you know that. I've got some questions that are coming in. I think what I'm going to do is let Kim go ahead and talk, and then I'm going to read the questions and I'll come back and answer them so that I've got a minute. So, all right?
Thanks,
Kim.
Wendy. Good morning, everyone. Just want to emphasize, again, this is not new information, but I think in light of everything that Wendy has shared with you, it's a good opportunity, just as a reminder, can't say it enough, monitoring, screening, planning. Those things are key. They need to be ongoing and continuing. Just so you guys can, I think, help to understand this, you need to be conducting assessments right now of your agency's infrastructure and identifying those emergency plans and making sure that they're in place. They should be in place. You should be doing constant kind of reevaluation of those plans as things continue to change. Part of those plans need to include your evaluation of, do you have the necessary resources in place, whether the resources that we're talking about be staffing, whether they be PPE to support your residential needs, to meet the needs of the individuals receiving services in the event that either the residents become COVID-19 positive or your staff. And there are different variables there depending upon what types of situations you encounter. So again, be thinking through that as you're working through your planning and developing your policies and procedures. Also be thinking about, as you know, we've reopened in Missouri and individuals are starting to access community activities and going to other services out in, such as day programs or employment. Be thinking about what are, like Wendy mentioned, be thinking about what is your communication process with those respective service providers as well. Also, ongoing evaluation and communication with the individual's healthcare providers are crucial. Making sure that the plans are being updated and revised and everybody has a clear understanding of what are the strategies and testing plans for individuals if they're potentially exposed and they're notified of that. How are you communicating with that primary health care provider? What are the important things to be monitoring for specific individuals? What is the process for if there are changes in that individual's status, for who needs to be notified and what action needs to be taken? Those are not things that you need to be looking at, considering or implementing or putting into place at the time that you get notified that you have either staff potentially exposed or positive or residents. So again, we cannot stress and emphasize enough the importance of ongoing daily screening of your staff each shift, ongoing screening and monitoring of the residents in the home, and that monitoring may look differently, again, based upon that individual's needs and in consultation with their primary health care providers. Staff need to be educated and informed about what they should be concerned about when they're conducting that monitoring. What is your agency's policy if you have staff show up and they're screened and they are symptomatic? Everyone needs to be fully aware of what those expectations are and what your agency's policies and procedures are for those things. And we have lots of resources out on the website to support you in your efforts around monitoring, screening, and planning. So please feel free to reach out to your local regional teams who can guide you to access those resources if you need that information. Another thing I want to remind everyone about is part of that planning and evaluation is you might identify that you may have the need for an alternative care type of support if you have a particular home where you're providing services where individuals may not be able to self-isolate or quarantine. Again, now is the time to be thinking about those potential situations and be planning so that we can work with you at the division level to support you on accessing maybe some of those alternative care site providers and some of those resources. So again, just cannot emphasize all of that enough. I think at this point, I'll just turn it over to Angie for any updates that she might have.
Do you want me to go, or do we want to do some of those? No, go ahead and go. Okay, so good morning, everyone. Just a few things from me. We did hold our public comment forums this week for our waiver amendments for the comprehensive and community support. So again, we really appreciate everyone's time on those. I know it was different formats, but we did get some good questions, and hopefully that was beneficial. So just want to remind everyone that the questions and comments are due by the end of the day, August 17th. And then after that, we're going to make any necessary adjustments that we need for the waiver renewals. And then we will submit those to MoHealthNet by September 10th for them to go through the formal process, submission process to CMS. So there will be one more public forum comment period once it's submitted to MoHealthNet, but we like to get as much of it cleaned up as possible before then. So please send in those questions and comments. We also want to remind everyone that we will be amending waiver amendments, and you'll see the we'll be submitting waiver amendments, and you'll see those coming out soon. And that will be to remove person-centered strategies consultation as well as counseling services to be effective March 1st. We have posted a memo on our website that explains the removal of those services and the steps that we'll be taking. For those individuals that are receiving those services, the division has a transition plan that they're working on, and we will be contacting those individuals and the providers of those services, and we'll be working with the planning teams to transition those accessing those services to other means that appropriate resources and means that we have available. So we do have other options in the division that we use that can take the place and actually probably have more assistance to them than those services. So we think it'll be a good change. One thing that came through this morning that we got, and many of you may already know, you'll probably start seeing things on the news or some email blasts out, but at the federal level, Secretary Azar signs that the public health emergency has been extended for 90 days. In Missouri, Governor Parsons has extended ours to December 30th, but just so there's no confusion, at the federal level, it was to end July 25th, and it was signed yesterday to extend for another 90 days. So we do have the two different public emergency proclamations that we're working under. So, and I think with that, I'll turn it over to.
No, we're going to go ahead and answer some questions while we're kind of in the mode of talking about programmatically. Gary's got some questions. I've got some questions. Kim, do you have any questions? And then when we're through the question phase, Carrie Tessero is going to give the fusion cell update that Val would ordinarily give. So go ahead, Gary, you want to start?
Okay, I'll go ahead and start. Question about is Station MD equipment and eligible COVID cost when applying for the provider funds? I would say yes. So that would be a good use of that. And is PR who you should reach out to about CARES Act funding? So yes, PR is going to be the lead at the regional office. They're going to take the applications and the attestations you fill out and just make sure everything's in order. They're not going to go through with a high level of scrutiny on what you're requesting. So that, I mean, they're not there to question what you're asking for. But if they see something that's really just out of the ordinary, they may question it. So, or if your numbers don't add up. So if your invoice doesn't add up to what's on the attestation, they may send it back to make sure it matches. Because since, you know, we're in possession of the document, you know, in an audit, we have to be able to produce this stuff. Just know that, you know, so they're pledging to have their process done within 5 business days, you know, if everything goes well, hopefully sooner. And then it'll come to central office where we'll process the payment. So yeah, so PR is the lead at the regional office. And then a question about, will Station MD be expanded for psychiatric services? They heard that Station MD, I guess from them, that was a separate service. I've never been aware or heard that they offered a psychiatric service. So I would have to, I'm going to follow up with Station MD and see if they're familiar with that question. I think from what discussions with them is that, you know, they can handle behavior questions as much as any physician could in dealing with medications and that type of stuff, but I was never aware that they had a separate psychiatric service, but I will follow up on that. And then there was a question about remote visits, how you're supposed to bill under that, and RCFs are technically still closed, so how can they start community integration with them? You would still bill, and if I think more detail would help, but if I understand the question correctly, you still bill under your normal codes. What you add on to it is the place of service code of 02 for telehealth, that service. So you'd still bill the community integration code, but you'd add 02 that it was done via telehealth, if I'm understanding the question correctly. And what are the approved sites to use for virtual visits? Is Google Duo on the list? I'm not aware that we have a list, but I'm looking around the table.
There's, on several of the guidance documents that we have out there, there is a list of secure and some examples of those that are public facing and can't be used. So beyond that, I don't know what it is. You would just need to find out if that, you'd need to do some research to find out if the tool you're talking about is public facing or meets the criteria that we put in that guidance.
Okay. I think that is all the questions I have.
Okay. Angie, do you want to speak to the Appendix K question?
Sure. A question came up about whether or not Appendix K needed to be updated with the open air visits, and we do not need to update Appendix K with open air visits. Our Appendix K waiver covers which language should be sufficient, so no changes there.
Okay. And then there was a extension of that question. It says, with regard to service providers having mobile video capability, is the provider responsible to pay for the internet service and hardware, or is that to be paid by the people who live in a particular home, or should it be a shared expense? With the CARES Act funding, you can submit those expenses for the internet or the technology needed through your CARES Act funding and use that while we've got that. So that is one avenue for payment for that. Also remember that if you're using StationMD, MARF has a grant for technology, and some of that is for tablets so that the doctor can have a video chat and visit with the person. So that might be an avenue for you to get some of that technology in the home and funded that way. I think that it is possible and fine for there to be some sharing of expense, maybe for internet. Probably somebody needs to own the hardware itself. But if you're working with an individual to stay connected with family through FaceTime calls or virtual visits, and using Facebook to be engaged with activities, and that person has the financial resources to purchase a tablet, that's okay that person purchased the tablet and it be used for remote visits with the TCM. After all, it is communication with that individual. So it does involve that individual 100% in its purpose for the visit. So I don't think that there's any reason why it can't be owned by the individual if they have the resources. I
think if the individual has the technology, it's fine to use that technology that they're using. Yeah, absolutely.
Yeah, and if they already have it, you can certainly use it.
Yeah.
If you want to work out some arrangement, maybe to share some internet costs, those are things you're going to have to work out as a team. You know, make sure that the families or the guardians are on board, that there's resources for it, and that the individual is actually also using that internet for their own personal purposes. If they wouldn't use the technology for anything else and wouldn't be using the internet for anything else, I don't think it's fair for them to have to maybe share in the cost of that internet, because that's a business expense. So I hope that helps answer some of those questions, but it's really, again, about problem solving and getting agreement amongst the team, and that everybody really be in agreement and on the same page. And again, if we can help you problem solve, your regional office staff have probably done that on numerous occasions already for different kinds of things where technology is considered. It says last week, another question, last week, there was mention that DMH is going to mandate COVID-19 policies and outbreak plans for TCM agencies. Is there more information coming on this topic? We believe that every contracted service entity should have policies and practices in place that should their business suffer from an outbreak, that they have contingency plans about how they're going to monitor. I guess the mandate thing is throwing me off a little bit. I don't think if we're not mandating right now, I think that's probably a conversation to be had, because I can't imagine that any agency would not have policies and practices in place about how they're going to do remote visits, how they're going to cover cases if one of their case managers goes down or gets sick or on vacation or quits, how they're going to provide PPE and protections and rules around documentation and all that kind of thing. So if it has to be a mandate, we can make that, I guess, but I would think that everybody would just have that as a part of their business.
You had a follow-up question to your comment that they should be going out, coordinators should be going out if they're getting concerns, that people have welfare concerns. They're saying, what should they do if they try to go out and the provider refuses or won't open the door or the windows?
Then they need to report. They need to report that to the regional office and to the guardian immediately, and we'll need to figure out what we need to do in order to resolve that issue. But don't let that go. That's an immediate report to your regional office. Okay. I got one here that I'm going to hang on to for Ika. There's a question coming to you. If at the end you can show it, is where is the education tab again? I missed how to get to it. So before we wrap up, will you please show people where to get to that tab again? Dwayne wanted to remind us that workshops are not monitored by us. That is true, and that they have a different set of rules and standards that they're going by. And so providers need to be really aware of what those rules and standards are. And again, you have to be comfortable that they are operating in a way that protects the individuals working there through social distancing and wearing masks and that kind of stuff, because ultimately they're going to come back home to you and to the other folks in the home. And so just as a responsibility to all parties involved, everybody needs to be comfortable with what the practices are in their counterpart agencies. Okay, I think that gets to Dwayne's point and Dwayne's question there. What about day programs which do not require masks for staff or individuals, nor do they take staff or individual temperatures? Again, we could mandate that. I'm kind of flabbergasted, honestly, that any program that would be following that kind of practice or not having a practice in place like that, that would be an example of a place where I would not send my individuals to the day program if they're not taking any precautions. We had said you need to be sure that you've got precautions in place, that you're assessing the individual's ability to wear masks. Staff should be wearing masks. There should be cleaning protocols in place. If none of that is in place and there's no screening going on with individuals coming in, I'm just going to say it straight out, that's not a safe place to be. It's just not a safe place to be. So if that is going on anywhere, that agency or those agencies need to take a serious look at their protocols. And if as a residential provider or a family member sending someone to a day program or having trouble or concerns getting compliance with that, please call your regional office, call central office, and we will work with those providers to get those practices in place. Or I just can't imagine that those day program providers would have any residential provider or any family who knew that was not going on, that they would send people to that day program. That's amazing to me. So there's that. And last question, I think.
I have another one.
Do you have another one? Angie has a question. If we do FaceTime visits only with support with service coordinators, do we have to get approval from Val? We are not giving approval for FaceTime visits only. So don't ask for approval to only do FaceTime visits. It is open air. If the county is not closed, is not identified on the list as a remote-only county, then you are expected to go do in-person visits. If you are doing a remote, if you're in a county on the list and doing remote-only visits, the FaceTime visits are good and can be a stopgap, but please be diligent about not just talking to the person for a couple minutes, or I want to see their arms, I want to see the person standing back, I want to talk with them and view them long enough to know their demeanor. As their demeanor changed, how are they doing? How are people interacting in the home? I want to see the kitchen floor. I want to see the bathroom floor. I want to know that the conditions of the home are meeting the standards that they need to meet. So even if you're doing a FaceTime visit, please be sure that you're doing a really thorough visit and seeing everything that you need to see if you were standing there in their home 7 months ago. So I hope that gets to it. Val is very committed and has repeated that she feels like we need to put eyes on people. I second that wholeheartedly. We need to put eyes directly on people, even if it's through a patio door or through a window. So she is not going to approve video visits, virtual visits only, as an alternative to doing in-person open air visits. So anything that anybody has to add with regards to any of that? Okay, Angie's got a question that she's going to speak to.
So we just wanted some clarification. It's the person-centered strategies consultation and the counseling service, that will be removed from all 4 of our waivers. So from the Partnership for Hope, the Missouri Children with Developmental Disabilities, comprehensive, and the community support. We did have it in our forum on the comprehensive and community support just because we wanted to make sure people knew that it was happening because they had not seen any waiver amendments yet. So again, it will be removed from all 4 waivers. And then that is all I had. So I will turn it over to Carrie.
Yes, thank you. Heike, if you could share the blue, thank you. So I'm really just going to talk today about numbers a little bit and about where we are with the numbers in Missouri, and that's going to be my Fusion Cell update for you. A couple of big things we've been talking about this week. Obviously, numbers are rising. We're seeing that throughout the state. We're all aware of that. But also the average age of the individuals has shifted dramatically. So if you are able to see the screen, there is a chart on here that has the age distribution by bar chart. And so it's 10-year increments, starts from 0 to 10, then 10 to 20, 20 to 30, et cetera. And so that is a distribution of the number of cases. And if you can see the screen, you see that it's very few children. The scale goes up to 1,000 on the chart. So the 0 to 10 range is about 50 kids that were diagnosed between April 11th and May 11th. Then it jumps up for the 10 to 20 range. It looks like it's about 220, 25 people. The biggest group, it was the 50 to 60 group, which was just under 900. Your 20 to 30, 30 to 40, and 40 to 50 were all real close, between 750 and just over 800. Going down the back side of those age groups, your 60 to 70 age range was just over 700, and then your 70 to 80 dropped to about 550. 80 to 90 was around 500. 90 to 100 was around 250. I'm sorry. And then 100 to 110 was just a handful of folks, maybe 10, 20 people. So it was pretty evenly distributed throughout those ages 30 to 70.
Carrie, you need to move closer to the mic.
Okay. Next slide, please, Heike. On the next slide, when she pops up there, you can see the change. Now we're on June 11th to July 11th, and it has dramatically shifted the scale on the left of the chart has gone up to 3,000. And so you can now see that we have a much larger distribution of cases in that 20 to 30 age range. The 0 to 10, so our small children are up to almost 300. If I can get that, no, I'm sorry, almost 500. The 10 to 20-year-olds are up to nearly 1,200, and then of course the largest age group is now that 20 to 30-year-olds. So what we're really seeing is a downward shift of the individuals in age, and we're seeing a lot more families that are getting it. So mom and dad, maybe in the 40s and 50s, the young adults in their 20s to 30s, and then also the kids. So teenagers and young kids under the age of 10. Next slide, please, Heike. So the next one that I wanted to show you, this is just some comparisons that they have done. In the left-hand side of the chart, they are looking at the deaths per 100,000. So they're looking at the death rate. And they look at it per 100,000 population so that they can compare kind of apples to apples, different locations, despite the fact that they have very significant differences in population. And so the interesting thing about this chart is New York is number one with 165 per 100,000. We all know that New York got hit very hard, very early, and suffered a lot of deaths. But the most interesting thing on this is some of our county comparisons in rate compared to some of those other ones. And you'll notice that Gentry County, St. Louis County, St. Louis City, Scott, Stoddard, all of those counties make the list when they're looking at those rates per 100,000. So they're quite high in some of these counties. Then the second chart on there is just your case rates. Again, per 100,000, it's adjusted so that you can see, compare different locations based on their population. And you'll see that McDonald County has a concentration higher than the state of New York did, higher than Arizona does, and several of the other hotspots that you see around the county. So what that's really telling you is for the number of people in McDonald County, they had a higher percentage of people who were diagnosed with COVID-19. And we have several other counties that make that list as well. So just that is something that was shared on the Fusion Cell with everyone, and we're sharing it so that people have an understanding of how we compare around the state to other places and how the disease is changing and impacting in Missouri. And then, Heike, if you could pull up the other slide, please. And so then this is the last thing that I want to talk about. I know we've had several requests from counties to be added to the remote-only list, and we will be updating that list again on Monday. We will be pulling all the data from the State Department of Health that they get completed over the weekend. The Department of Health is behind right now in their entry of positive cases, and so you can see on the screen that they are currently, as of 8 o'clock this morning, behind about 8,405 positive documents that need to be completely evaluated and entered into the system. Now, that is part of the reason that we've had such large increases over the last several days. That's also part of the reason why we've had such discrepancies with some of the numbers that the counties are saying, hey, these are our numbers, and we can't match them with the health data. All of those that are showing as positives that are a backlog, the 8,400, those are not all new cases. They estimate that only somewhere between 10 to perhaps 35% of those are actually new cases that we don't know about and that we are not counting. That's still a large number. It's still very concerning, and it's definitely a high priority to eliminate this backlog and get all of those cases entered and counted. There's a significant number of reasons why there's a backlog and why there are multiple reports. All the labs are required to submit their positive reports to the department, positive and negative. But in addition, if a doctor ordered the test result, they may also report the positive result back to the state health department. The local public health agencies, if they're getting the test results earlier, they're also potentially reporting back. And then some of the labs in their reporting process simply send their master file every day, which means they're not sending the department just the new ones, they're sending everyone every day, and the department has to weed through those and figure out which ones are new and which ones they already had. So all of those things factor into this backlog, but also the sheer volume. The department is receiving probably close to 10,000 results a day, and a lot of those do have to be manually entered. Like I said, it is top priority to get this backlog
caught up. They hope to have it completed or near completed through the end of the weekend. So hopefully on Monday, when we are able to put out our new list, we will have all of this data included in it. They have dedicated more resources, more people. They are working multiple shifts a day in order to get this information entered, and we are also bringing on a new electronic system slated to start coming on board August 1st. And I say start coming on board, it will be put in place, but they will have to onboard providers into it, which will be a bit of a process, so it'll take them a couple of weeks, but they obviously will start with those biggest reporters. So as many of those larger reporters that they can get coming in electronically that will reduce the manual entry will also greatly help us with this issue that has just popped up. And they are, of all of those cases that you see on the screen that they're behind, that goes back to about about July 20th. So it's about a full 5 days behind. They have been making great progress. They were hopeful to get it caught up by the end of this week, but they've got significantly large influxes, even above and beyond what they had been seeing this week that they were not anticipating. So that is some of the issues we're facing, and hopefully they will get resolved over the weekend, and then we will put out a new list on Monday.
All right, thanks, Carrie. I've got another question that came in that I'll clarify on, and then if you have any questions in regards to the fusion or anything else, you still have a couple minutes to put a question in the chat that we can get to. So there was a clarifying question that around the policies being required around COVID-19 policies and outbreak plans. So last week I did say effective immediately that all service providers had to have a COVID plan, an emergency plan, a risk mitigation plan, call it whatever you want to call it, but policies and procedures around how they were going to protect the clients in their home, what are the cleaning policies, what are the PPE guidelines, what are those practices for sanitation if you get a positive test result. How are you quarantining people? How are you isolating people? What are those protocols in place?
Staff screening every shift.
Staff screening every shift.
Individual monitoring daily.
Testing. What is your policy on testing? How are you going to do that? How are you going to monitor clients' health throughout the day, especially if you have people that you know have been exposed and those kinds of things. So those are specifically policies and procedures, and a plan in place is required for service providers. How are you going to manage all of those details? Another part of that question came in about, do we have anything out there? Are we going to be providing anything as a checklist to be sure that everything is covered? I think there might already be guidance out there in some of the resources about the risk plans and the mitigation plans. We can have some conversation about that internally, and we can look at that to see if it's not out there, but I would suggest that you review those. The DMH staff are not going to be critiquing your plans or your policies. They're not going to be telling you if they're right or they're wrong. They're there to help you problem solve and brainstorm and think through some issues if you need that support and consultation from them. What they're going to be looking at is to be sure that you have a policy around PPE, that you have a policy around quarantining and isolating and all of those factors. So they're not going to be critiquing what your plan is, but making sure that all the components are in place.
Yeah.
Kim, did you have anything to add to that?
Thanks, and again, it's just about preparedness. You don't want to be in a situation where you're not prepared through your planning and your policy efforts, that all of a sudden you have someone present who is positive, and then you're trying to figure out how you're going to support the individuals, how you're going to meet your staffing needs, how you're going to be able to provide the necessary PPE and resources. That's really what this is about, is being prepared through the efforts of planning and your policy development.
And by extension, I would apply that same rationale and need to our TCM agencies, because just because people get sick doesn't mean that your responsibilities for monitoring go away. So you need to have plans in place about how you would ensure that you'd be able to continue the responsibilities under your contract if there were interruptions into the service. So Really great questions this week, guys. Really appreciate you hanging in there and asking these questions, putting them in the chat, giving us an opportunity to clarify things. You know, as best laid plans, we always think we're being really clear. We try to be really clear, but there's 1,000 different ways to hear something, and there's 1,000 different ways to say it better. So appreciate you all hanging in there with us and helping us to get better communication out there. Kim, do you see anything else over there in the chat?
Just questions about the policies again, and we'll follow up on those questions.
Okay, we'll follow up on the questions or more about questions in the policies in our question and answer afterwards. And so, Heike, I'm going to punt it back to you so you can show people where that education button is.
All right. So I have shared my screen again, and you should be seeing our division landing page. With that, scroll down just a little bit, you'll see the Community Supports tab. You click on the Community Supports tab, you will see a lot of our program areas listed here that you can get to their pages individually. But you'll click on the Education and Learning, and this will bring you to those tabs or those areas that I discussed earlier. So if you have any questions about those or you run into something specifically, or especially, I should say, with Reliance, feel free to reach out to me directly. If you're finding that there's some additional information that would be helpful, we're happy to get that guidance put together and get that posted for you. And if there isn't anything else that has came in through the chat box, then I think that's a wrap for today. So thank you, everyone, for joining us, and we'll be back together next Friday.